So good morning, everybody. My name's Tom Ray, and it's a real pleasure to be here on behalf of our group. We're really excited to talk about some of the things that have happened in our communities over the past few years or the past few decades, as the case may be. And you've heard that if at first you don't succeed, right, the rest of that statement is try again. And I think that's very important as we move forward. So here are my disclosures. And I just wanted to take 1 minute to reflect on ECCU conference in general. This is really a special conference. It's a unique experience. Many conferences that I go to focus on information, on science. And as Vinay indicated, this is really a special place because it does provide the science, but it really then moves beyond that to try to motivate and ultimately to activate you all to go back home and make a difference in your community through what we would call local implementation. And I think that's really critical here. And again, I really, my hat's off to the organizers and the visionaries here that put this conference together. All right, so here's the outline. We'll give a framework. I'll provide a framework, concepts for a system of improvement. We'll do some community spotlights, and then we'll look forward. I think it's important to understand that when we were asked to present, each of us thought we'd have 45 minutes. And Dr. Ned Carney quickly told us, no, you have a total of 45 minutes. And so last night and yesterday afternoon, we dutifully pared down our slide set, but I still think we're going to move very quickly through our presentations. And I would invite you all to stay for the second session if you want to get down into the details a little bit more. All right, so framework of implementation and improvement as we consider it from the Pacific Northwest, right? So don't yell this out. If you know the answer, that's great. Please keep it to yourself. But I would ask you, what is this graphic? What does it represent? And we'll come back to that answer shortly. So people sometimes have this impression that when we drive into Seattle, there's this nirvana, right? We're in a glass bubble. But I would tell you, we have just as many blemishes and warts as any other system, right? It's hard work to do emergency care, and we experience that. And this is our first medic unit from Seattle, right? It wasn't fancy, it wasn't fast, and we've had to improve on that over many years. I think one thing that we did get lucky with, some serendipity here, is we had a strong medical presence from the very get-go, and that's Dr. Leonard Cobb, Mickey Eisenberg, and Michael Kopis. And they asked fundamental questions, not how shiny are our vehicles or how much money is in the coffers. Really, are we doing a good job, and how can we get better? Every day they come to work and they ask that fundamental set of questions, right? And they thought about, well, how will we know? Well, there are a lot of subjective and maybe somewhat objective responses for how you sort of gauge your performance. But I think fundamentally they wanted to measure, right? They wanted to understand, are we making a difference in the health of our community? And so they thought about, well, what condition will provide that best surrogate for how we're doing, right? And cardiac arrest checked a lot of these boxes, right? It's of public health importance. Pre-hospital care almost always determines outcome, at least in many cases. It tests all components of the emergency system. We can measure in detail the process and the outcome, and there's an opportunity to improve. And so resuscitation checks all those boxes. It is an excellent surrogate for your emergency system. Not the only surrogate, but an important one. All right, so if you would interview these three gentlemen, I think, and we have over the years, they would come up with a set of concepts or criteria that would define a good system, right? What are the fundamentals that make a system work? What's the framework for success? And that is to understand the science, right? This dynamic between leadership and teamwork. And then finally, you need to measure to improve. So I'm going to walk through these relatively quickly. The first is to understand the science. Right, so this metaphor, the links in the chain, has been incredibly useful and serviceable and continues to be. But I want to also share with you one of our metaphors for this, and that's the slope of death. And I know that sounds morbid, but that's Dr. Eisenberg's words, quote unquote. And what is the slope of death? Well, on the y-axis you have survival, and on the x-axis you have time from collapse. And your chances of survival slip away with time. And so you're challenged to think, well, how can I improve and how can I make this happen? You may say, well, in our communities, our response intervals are 4, 5, 6, 7 minutes. We we are able to push up. But if you really look at how your system is doing, I think you'd be surprised. So here's a graphic that comes from Arizona, where they looked at not just response interval as we often characterize it, which is wheels rolling to wheels stopping, but they looked at, and that's that middle blue section, right? It's about 5-6 minutes, but they looked at the time before the wheels actually started rolling and the time after. And when you add up all those time intervals, it actually comes to 13 minutes. And I think that's pretty common in most systems. We just looked at this in Seattle, and indeed, half the time of response is spent before the wheels roll and after the wheels roll, right? So I think it's there's a lot of hidden time that ticks by and makes the challenge that much greater. So what do, right? Well, we go back to Dr. Eisenberg's slope of death, and we want to change that trajectory. How do we do that? Well, you all know this better than I. It really is about early intervention here. So if you can employ bystander CPR early, you can bump that survival from 10% to 20%. What if that bystander CPR was started even earlier and was of higher quality, right? Now you're up to 30% potentially, right? And then the last intervention that we think is so critical here is high-performance EMS CPR, which we feel really suspends the dying process and enables other therapies to work. So we use the metaphor, the links in the chain, but we also think about the pyramid of resuscitation in our world. And we really emphasize those early links, the things that many of you are involved with, because we think these are the foundation, and without them, the opportunity to invoke and use those later links goes away. All right, so let's talk a little bit about the recipe for progress. And I think Tor Lerdal talked about the Utstein formula for survival, science, education, and local implementation. I think this is a very useful model to think about. When I think about it, I speak in metaphors here. I think of science and education as the sand on the beach. It's great. Right? We enjoy the warm sand between our toes, and it makes us feel good. But ultimately, what we're hoping to do is build that castle, right? And that is implementation, right? We have to have local implementation to make the science and the education work, right? So when we want to understand the science, yes, we like to talk about that in generic terms, but we also have to understand the science and the art of implementation and local implementation. So that leads us to the second leg of that stool, right? So understand the science is the first leg. The second leg is the science and art of implementation. And if you were to ask Dr. Eisenberg, well, what does that really mean? How do you create that culture of excellence? He would say it's a delicate balance between leadership and teamwork. Resuscitation is ultimately a team game, right? You cannot be successful unless you have every member of the team participating. And so you have to create this shared accountability, right? You have to take responsibility, not just as a leader, but you have to invoke that responsibility and accountability across the team. So here's an example in Seattle and King County. Right, you can log on and you can go to the EMS division and go to reports, and there'll be a published report, an annual report, and on pages somewhere in the 40s usually, there's 3 or 4 pages on our cardiac arrest care and outcomes. And we publish that every year, and we send those reports, as you can see across the bottom, to our fire department colleagues, to the hospitals, to public health, and to our elected officials. They know it's coming, they expect it, and when things don't go as well as they had hoped, they come quickly and ask questions. This is a kind of shared accountability, I think, that has produced some success in our system. Right, the last leg of that stool is really this fundamental commitment to measurement. And there are a number of platforms to measure. We've used CARES. It's been very serviceable for us. But I think it's important, whatever platform you use, that you commit to this and you do it year after year, year in and year out. And I think that's important because you need to put a stake in the ground to understand where your system is and how you can get better. And really, after 15 years in this field, I now appreciate that for every well-intended consequence and change in resuscitation, there is an unintended and unexpected consequence, right? And I think a good example here might be the advent of AEDs. AEDs definitely enabled earlier defibrillation, right? But we think in hindsight, they actually introduced a lot of interruption into CPR. And we didn't see the big boost in survival that we had hoped for with ventricular fibrillation arrest. And so, of course, we've worked those bugs out, and I think now many communities are enjoying better survival. So here are the 3 stools. Understand the science of implementation in particular. That involves your community. Leadership and teamwork, that's an important dynamic. You have to have shared accountability. And then commit to measure. So there are a couple of organizations that I want to highlight here. Heart Rescue and the Resuscitation Academy that really have understood early on that we need to commit to local implementation if we're really going to see the benefits of all the science and all the education. And so Heart Rescue is a state-based initiative here in the US that originally included about 5 states and now is up to 17, and really fundamentally challenged sort of the ivory tower institutions to engage their entire state in a measure and improve process. And it really was transformative, right? No longer could you sort of hide away in your world, but instead you really had to go out and talk to community leaders from across your state and work to improve resuscitation one community at a time. And then there's the Resuscitation Academy, which is really a forum and a resource to transform science into action, right? Really what we're trying to do is give people adaptable programs. They can go back to their community and actually implement in a useful and effective way, right? And I think if you think it's implement, measure, and improve, repeat, 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 right? That has really been, and the nice thing now, I think the encouraging thing, the exciting thing even, is that this has gone viral in some way, right? And now we have, and you heard Tora Laerdal talk about the Global Resuscitation Alliance, right? Again, the Global Resuscitation Alliance is focused on local implementation. Not the science, right, but really how do we make this work in a range of communities given those resources. It really is, I think the time has come for action and smart action, right, local implementation. So the Global Resuscitation Alliance is now involving 4 continents, right? North America, Europe, Asia, and Australia and New Zealand. And I think Freddy will talk a little bit more, and then in the second session after this we can expand further. So back to this graphic. What is this graphic? So this is outcomes from the Utstein group, witnessed ventricular fibrillation over time. Okay, and I want to make a few points about this slide. So the first is, I originally created this slide, and at the bottom was 20%, and at the top of the y-axis was 60%. And that curve looked pretty steep. And I showed it to Dr. Eisenberg, all proud of myself, and he's a very gentle person. But at that point, he sort of took me out behind the barn and kicked me around a little bit. And he said, absolutely not, right? You've got this all wrong. The axis is 0 to 100%. And we need to understand that we're only halfway there, right? We need to do better, just like, you know, when he asked those fundamental questions at the get-go. The other thing I'll point out is that this has been a 2-generation activity for these gentlemen, right? They've spent a career working on this to achieve essentially a doubling of survival. Now, they've learned a lot along the way, and many systems can be much more efficient than what's happened in Seattle and King County. But again, this has taken a long-term look at the issue. The last is, as you can see, there are years when things don't get better, or when things actually dip a little bit, right? And the idea here is to persist and stay at it. So here's just a sampling of some of the QI activities and some of the research that we've done in the last decade. I think most of these, the reality is, have not been successful, right? Resuscitation is hard. It's not an easy game. And yet, some of these things actually have yielded real benefit to our community, right? Early CPR, especially through telephone CPR, high-performance EMS CPR, and efforts to achieve early defibrillation, whether that's public access or law enforcement, anything we can do to get there sooner. But a lot of these have not. And so I think fundamentally they would say we need to celebrate the success, absolutely, but we need to learn from the failures, right? We can get smarter about these things, and that will benefit our community and hopefully others. So at this point, I'm going to turn it over to the Chicago group and let them carry on.
So again, I'm Teri Vanden from University of Illinois, and this is my colleague Teri Campbell from University of Chicago, and we are part of the Illinois Heart Rescue team. There are several team members in the audience as well. But this actually started, no story of Chicago would be complete without a preface that starts with Mickey Eisenberg. You saw his picture before. And it was really a challenge from the West Coast that, Chicago is one of many large urban centers that had very low published survival rates. And again, we talk about this notion of an alliance. One of the advantages of being part of a network is that you know that there are ways to do things better, and we are inspired by Seattle to move forward with the Heart Rescue Program.
Yeah. Okay, very good. Sorry, I'm short. Okay, so every time I do a grant report, I email Mickey, and I'm like, Mickey, time to publish a new book. So I just want you to know. So let me give you a little bit of background of some of the humble beginnings we had in Illinois. So when we started our project, the only data that we had available was pre-hospital data from the Illinois Department of Public Health. And the information that we had was what fire departments would report when they dropped off at hospitals. So we knew for the state, 4% of the patients that had an out-of-hospital cardiac arrest had a pulse at hospital drop-off. For the city of Chicago, it was only 2%. We had no information on patient outcomes. Many of us in this room know that a fleeting pulse does not equal ROSC, or return of spontaneous circulation. So in addition, we had multiple fire departments that said, wow, we're not even at 1%. So they started looking at their own practices, and they realized that at that time, many of the fire departments had what we call in EMS a load and go philosophy. That meant fire departments would drive up really fast, they'd throw 3/4 of the way dead people in the back of their ambulance, and they drive away really fast and then drop off 100% dead people at hospitals. So they really looked at those protocols and have wanted to and started to adopt the new philosophy of stay and play. Work the patients where you find them. And again, we can go into a deeper dive in our breakout session. I'm going to try to keep this brief. However, as a result of dropping off 100% dead people at the hospital, it eroded the attitudes of the EMS providers. Really, myself included, when I started in this as a wee little nurse, is that people didn't survive cardiac arrest. So what happened was, in EMS, resuscitations, really the attitude began really becoming that patients aren't gonna survive anyway. So let's make this a skills fest. Now, I'm sorry for the lay people, but that was the honest answer. We gave our new clinicians time to practice skills like intubation and lines and things like that. Even at the hospital, we'd do one token round of resuscitation, and then we'd call the code. So this is a problem. We needed to change that attitude. So thankfully for us, with Illinois Heart Rescue, Chicago had an early recognition that they had a problem. So they were actually very easy to engage because they had already been working behind the scenes. Now, they had hesitancy because they had egg on their face, both from Lance Becker, from Mickey, that there was a bunch of publications that Chicago and Chicago Fire was not the sexy TV show that we see today, right? So they wanted to improve, but they were very worried about having egg on their face again. There's 4 EMS medical directors for Region 11, which covers the 3-point-some million people in the city of Chicago. 2 of the EMS medical directors went to go visit Tom and Ann Dahl, shout out Ann if you're out there, at the Seattle Resuscitation Academy, and they came back really with this great attitude and this great energy. So they invoked the Illinois Department of Public Health. We started identifying other key stakeholders to make this dream into a reality. So Illinois Heart Rescue vied with 17 other states, and in September of 2012, we were awarded the Medtronic Foundation Heart Rescue Grant. It was a $2.5 million grant over 5 years. That, because I am super cheap, just ask my team. I've been able to stretch that money for 7 years. So let's do easy math, because there's people out in the audience saying, well, I could do amazing things with $2.5 million. So that's going to come to about $257K a year. And remember, this is an operating budget for the 5th most populated state in the United States. If I take it just to the city of Chicago, that's less than 1% of their operating budget. So I'm really challenging everybody in this audience. If you're a hospital, a fire department, a community, take 0.5 to 1% of your operating budget and put it towards out-of-hospital cardiac arrest, and you're going to do way better than we've even done in Illinois. So again, we were tasked with more than doubling neurologically intact survival, which we were very blessed to do in year 2 of our 5-year grant.
So one thing that I think is a recurring story, and this is something that Tor Laerdal brought up in one of the earlier plenary sessions, is that it's so important to be part of an alliance, and certainly that is extended globally now, but Illinois benefited from many other heart rescue states that had already started a process of improving outcome statewide. We were the 6th state among many. There are many other counties within these other states that participate in CARES. But we were able to call coordinators in other states. We would have regular ongoing calls and ask them what they thought about certain projects. I mean, one of the key things that happened was telephone CPR and taking advantage of the resuscitation academies out in Seattle is just one example of things that really helped us along. And those already existed as part of this alliance. The other thing that we did is we took certainly a page out of Mickey Eisenberg's own book, which his chapter that talked about Chicago talked about location, 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 and I think Chicago was already realizing that, as you can see in some of the red areas, that we had a much higher incidence of cardiac arrest. You can see on the upper left-hand side, that's O'Hare Airport. The city, and thanks to many folks that were working on that project, including Lance Becker and others, survival went from 0% at our airports to something over 60%. So we knew that if we focused on locations, we could really improve outcome long term. The question was how to do it in some of our many other neighborhoods.
Okay, so you guys can all read, so I'm not going to go over this timeline. Again, we can do it in greater detail at the breakout session, but you can see from a very high level that we were eating the elephant one bite at a time, and we had a very dedicated plan. To Tom's point, not everything worked, so we reevaluated, had a new plan, and lather, rinse, repeat. Okay, so some of the stuff that we know that worked. Telephone-assisted CPR, if any of you had the opportunity to listen to Ben Bobrow yesterday, he and Micah are doing some amazing stuff in Arizona. So our 911 dispatch center in Chicago is called OEMC, and once we went there and we trained the dispatchers to not go through a 15-page algorithm before they finally asked the question, are they responding to their name, are they breathing normally? When those answers were no, they immediately instructed for bystander CPR. We saw a tremendous bump in our survival in the city. Other things that worked, we were very blessed to rise on the shoulders of giants from other people in the Heart Rescue Project that were wonderful with sharing all of their resources. So we started having resuscitation academies also in Illinois. Free education, free continuing education, with the dedication that it was a pay-it-forward model. Simultaneously, Chicago Fire Department was having their own internal resuscitation academies on a monthly basis. They call it Incident Command for Cardiac Arrest. In addition, they review every single solitary cardiac arrest. They bring the crews back in, they go over the resuscitation, they do remediation, and again, now the crews have the attitude that we're in it to save people, that this is no longer a skills fest. Other things that we know that worked, at least for Illinois, was a very critical eye on our hotspot neighborhoods. Where was our highest incidence of cardiac arrest, and what neighborhoods and communities had little to no bystander CPR? We feel very strongly about community engagement versus community outreach. If you do not have partners in your community that are sitting at the table with you, that know that you are committed to them and they are committed to you, you will not be successful. If you are helicopter researchers, you fly in, you do an intervention, and you fly out, you will not bump that needle on survival. Probably the cornerstone of our project, at least for Illinois, is very much addressing health disparities. So we were looking at not only disparities in the incidence of cardiac arrest and bystander CPR, but how did that translate to survival and, more importantly, neurologically intact survival. So again, another of our cornerstones is taking it to the street, so really engaging the community. We've created videos and PSAs that are available in 6 languages. Illinois is happy to share everything with you for free. Everything's on the internet. Talk to me, I'll hook you up. We learned one of our lessons is that we couldn't hold grand CPR and expect people to come to us. We had to go to places where people were already congregating. We've done a combination of high-level, high-profile trainings that include Chicago Cubs, Chicago White Sox, the Chicago Bears. I've been having trouble with them. Truly, that team needs some resuscitation, but we'll get into that later. We've done multiple low-scale trainings, and the big cornerstone with this is that we will train anybody at any time if they promise they will be a pay-it-forward model, if they will then train their own community. So we've had a lot of success with faith-based organizations, schools, and park districts. This is just an example of some of our trainings. That's me in the center resuscitating Benny the Bull from the Chicago Bulls.
So there were a lot of public-private partnerships that came together. We had over 300 letters of support when we submitted our heart rescue application, and we really did follow up on those letters of support. There are a lot of community organizations that, again, as Teri said, there's a difference between outreach and engagement, and it was really critical to engage some of these organizations that included high school groups as one example. We have a Teen Health Alliance in Chicago that has a lot of wonderful leadership and great ideas about how to think about this. There's a First Ladies group that Walgreens sponsors every year. First Ladies are not in the White House. First Ladies are ladies within the church who are prominent leaders, and they have been great allies with us in this program. We have about 60% of all hospitals now in Illinois actually participate in CARES, which is really an amazing number when you consider we started with about 5 hospitals that said we really want to do this better. So that really reflects a big commitment on the part of many. But we have differences in hospital engagement, and these are ongoing challenges. I welcome advice from all of you as we become a global alliance. I think that we need to think about how we engage each other more effectively. The thing that we realize is that there are hospitals that have tripled survival rates, and there are hospitals that have not done anything. And as much as we would like to publicly put this out there, we would lose reporting if we did that. And so there is this tension. And then there are, of course, hospitals that want to put their results on a billboard and say we're a lot better than the other hospital. But I think we need to think about public reporting, and it gets into some of the sustainability things. The Illinois Hospital Association has certainly worked with us to design webinars. But again, the thing that we're seeing is that the hospitals that are already doing a lot and improving the most are the ones that are on the webinar. The ones that really need to improve the most are not on the webinar. And so how do we better engage those folks? But there are large disparities yet in Utstein survival between hospitals, and we need to address that as an ongoing challenge. So we had a law passed in July 2014. We're one of many other states that have an education requirement in high schools. We all know, though, that this is to some extent an unfunded mandate. It requires an honor system in terms of, Teri Campbell did her wonderful job in working with WorldPoint and others to get toolkits into our schools, only to find that they weren't necessarily using them. And we really had to work hard to get them motivated. And so we still are working on how do we validate compliance. Some of our teen allies, our community groups are helping us with this, but we can still do better in this.
So again, very busy slide that we'll go over more in the breakout session. But on the far right-hand side, those are the national averages. And starting on the left is 2013 and where Illinois has gone. So if you just look at the graph very simply, you can see that Illinois has done a tremendous job with trending up. So not on this slide, but on another slide. We started out in Illinois. Remember, our survival, which was pulse drop off at a hospital, was 4%, and at 2016 we're at 9.4%. So we really have made some tremendous strides. Some of the things that we're very proud of is our Utstein and our Utstein bystander survival. So if you look at our 2016, that's the light blue and the orange, we actually exceed national standards. Right up here, Teri. Okay. Oh, go on. Okay. Other things that we're proud of is our bystander CPR. Marina Del Rios is our physician lead for community engagement. We are out there all the time. Daisy Zamora, our community coordinator, is also here. So when we first started our project, our bystander CPR was well less than 10%. Right now we're at 27%, and something that I really want to point out is that although we're comparing ourselves to national averages of 39.7, Illinois refuses to include nursing homes, healthcare professional, or like dialysis or clinics like that, because we expect those clinicians to know how to do bystander CPR. The other thing we do is we exclude O'Hare, because our survival rate at O'Hare is 56%, because there's a healthcare professional and an AED about every 100 feet. So the fact that we've gone from less than 10% to 27% and excluded all those numbers, we're very proud of that.
So we still have more to do, but this is a graphic that Marina Del Rios from our community group has helped, and we're working on a publication right now to submit. But the red dots are where cardiac arrests occur. The yellow is bystander CPR. We certainly had a bump overall in the city with implementation of telephone CPR, but one of the things to point out is the other thing that made a difference is focusing on hotspots and really working hard to get into some of those areas that had a lot of red dots in 2014 without any yellow. And now we have yellow dots in many of those areas, and we're very proud of that, but there's more to do. We are very proud of the overall increase in bystander CPR and survival rates, as Teri pointed out. And
so I'm going to do this fast because we're like down to seconds. So what does this mean in terms of lives? Because it's fine that we show you graphs and it's fine that we show you statistics, but what does this have to do with real lives? So in 2014, we had 112 people that survived neurologically intact. In 2016, that went to 219. I am a nurse, not so great in math, but guys, let me tell you, that is 2 lives per week. If your fire department, if your hospital, if your school, if your community could guarantee that they could save 2 people a week, what would that take? How else can I convince you that this is important?
So then finally, some of our work has now taken us to India, as well as part of really a global health alliance there. Where we're at right now in Illinois is thinking about sustainability, and again, I welcome advice from colleagues here. And in our breakout session, I'd love to talk about this some more. We're thinking through proposed legislation, both at the state and possibly national level. There's a community needs assessment piece that needs to be incentivized. We're working with our high schools in many areas of Illinois to create health advocacy in a way that's really exciting. And then this Global Health Alliance, we're taking things to Bangalore, India, and beyond, and taking lessons learned. So I want to thank you for your invitation to tell the story of Chicago.
Thank you very much. Very interesting to hear your data and what you have achieved. The next one is from Copenhagen, Denmark, and there's a countdown here in front of me. It says that I hope it's not for the Lifesaver March this afternoon, because then you will all be leaving in 10 minutes. But if it's meant for me, then I have to hurry up for this presentation. Anyhow, the four of us will afterwards discuss in another session this more in details, and also we will also discuss how to improve further. So you got me introduced, have disclosure, or I would say acknowledgement. We get a lot of support from the Danish foundation Vanden, which actually supports saving more lives in Denmark nationally, and we also get support from the Lippert Foundation unrestricted research grants. The story I'm going to tell you is about 15-year. It's Hans Christian Andersen, famous fairy tale from Denmark, who wrote, for instance, The Ugly Duckling. And this is how we felt at that time in Denmark, because we had really bad results when we started measuring outcome from cardiac arrest. But in my opinion, it actually ended out like the fairy tale, as a beautiful swan in the end. We started in 2001. We had survival rate of 3% and bystander CPR rate of only 20%. And we thought, well, this is Scandinavia, this is a high-income country, well-educated people, social responsibility, and still we're not doing better than that. So we were a bit ashamed of that. We had a vision. We want to improve bystander CPR rate. We want to improve outcome, but we had no plan. So this was try and error all the time from that time. But it was a beginning. And this is actually kind of the story, and it's also my story within medical, my career. I started in critical care, intensive care units, worked there, made a difference to life and death, but it didn't improve survival from out of hospital cardiac arrest. I went to the trauma center, emergency department. We did that. We educated people. We had protocols for trauma care, for cardiac arrest. It didn't make a difference to outcome for cardiac arrest patients. Then I went to the ambulance services, worked in pre-hospital care, being medical director, and then also the dispatch center. And now I'm medical director or CEO, actually, of EMS in Copenhagen. And what made the whole difference here is actually engaging the community. We spent a lot of resources in the critical care units, and the outcome for cardiac arrest patients is that small. We spent less resources in the community, in the dispatch center, in the pre-hospital setting, and there you get the most benefit from what you're actually doing, spending your money. We started this with data collection and research, and we had some projects back in 2006 about the CPR Anytime school project. We disseminated AED, or we disseminated material into the schools at that time, published in circulation. We located the AEDs and tried to disseminate it in the community and made some community program. And that is actually how we tripled survival in Denmark. You'll get some data. The first time we actually published this was in 2013 in JAMA. Mads Wissenbjerg, who actually, well, this is a long title for saying we doubled and tripled survival in Denmark. And this is not just for Copenhagen, it is for the whole of the country. These are the results. Bystander CPR increased from 21% to 45%. Survival rate to hospital increased from 8 to 22. And 30-day survival, which is the standard, increased from 3.5 to 10.8. And 1 year survival is actually the same as 30-day survival. These are the curves. The red one is RUSC, return of spontaneous circulation. That is immediate survival out of hospital, and the other one is 30-day survival. And if you look at shockable rhythm, that was the huge increase there from about 10% to about 35% in that time period. But not much happened actually with the non-shockable rhythm in that period. There was one explanation to all of this, and that is the bystander CPR rate. So bystander CPR rate increased, it doubled, it tripled actually in that period. And this is back in 2010, and these are the new data. You can see it actually more than increased in this period, and that was because we made major changes in the dispatch center. We really put emphasis on what we call the team leader of the first resuscitation team, and that is the dispatcher. And the first resuscitation team is the dispatcher, the bystander, and the caller. We looked at AEDs. We have a national network that was part of the project. We have 16,000 AEDs for public access defibrillation. It is available for the dispatcher. They will be able to see the nearest AED when we get a call there. So we looked at the AEDs and we tried to make them available 24/7. We also came up with some recommendation on that together with the National Board of Health. And this has just been published in JAMA Cardiology as well. And here you see the development from AEDs. This one is the percentage being, or the numbers and the percentage here being used of AEDs by laypersons before arrival of the ambulance services. So in 12, we ended up with, as you can see, 15% of the cases in out-of-hospital cardiac arrest in public places, an AED was used by layperson, and survival rate in these cases are 50%. 50%. It's still low in residential areas, in private homes, and AEDs available in residential areas are also low. It has increased, the number of AEDs has increased in public places. And this is why we just started this 2 months ago, what you would call kind of pulse point, but it's a hard runner project where we actually, people volunteer and they go out for cardiac arrest in private homes to save lives, and we'll tell more about that in the next session. So is it worthwhile, all of it? Do people get back to work? We looked into our cardiac arrest registry. We have social security number of all, unique social security number of all our cases, and we were able, by combining data, to find out if people went back to work or not. So what is the percentage of people being at work, having a cardiac arrest, and going back to work? 75%. 75% actually went back to work. And we looked into the income that they have, and it is published in the journal, that the income that they have from what they are doing is actually the same as before their cardiac arrest, meaning that they have full recovery. Another interesting thing is actually that not only did the percentage of survivors increase, but also the percentage of people going back to work. Back in 2004 or 5, it was a smaller percentage going back to work, and in 2012 and 13 and 14, it's a higher percentage of people actually going back to work. But the average is 75%. And then we had another publication this year in New England Journal of Medicine. I don't have the time to go into details, but there's a nice link there telling, and it's focusing on bystander CPR and bystander intervention, using an AED, for instance. And it looks at the final outcome. What is the final outcome for people going to nursery home or to having a severe having difficulties in life and being depending on others. And here you will get a few of the data. Rate of bystander CPR increased from 66% to 80%. Bystander raised or defibrillation rate increased from 2.1 to 16.8. And brain damage in that period also increased considerably. And if you have bystander doing CPR and using an AED, you don't have any brain damages. That's a short message. That's an easy message to bring forward. Just to mention our results, these are Eureka. It's just like the CARES registry, different European countries, outcome, 30 days outcome, and this is Copenhagen being leads together with the Dutch people there. So how did we achieve that? Well, actually, there is a cartoon on YouTube. If you Google or look for Denmark, and you can save a life. There's a very nice cartoon comprising it all down to all the elements that was in that developing we have had. But we had an ambition to increase bystander CPR rate. We engaged the community, which is the most important thing actually, and increased bystander CPR rate. We had an AD network. We made public awareness of the importance of doing something as layperson, and we have documentation and science to actually encourage people that it makes a difference, a huge difference what they are doing. We also have political awareness, and it became political awareness about it, and we also got final support, legislations and things like that. We had the support from the foundation, and then we have national EMS collaboration in Denmark, which was necessary to achieve this. So as with other systems just mentioned, and with our system, when we look back for these 15 years, we actually had all the elements there. It was just a matter of putting it together in a nice way. And what we achieved by that, I would say, I started saying we didn't have a plan, but we tried and we succeeded, I think. But now we have a plan. The plan is the Global Resuscitation Alliance. When we look back on this, the recipe you get in the Global Resuscitation Alliance is partly what we used to achieve what we have achieved. But we didn't know that. We didn't know that it was the 10 steps to improve survival introduced by Resuscitation Academy in Seattle. So we just used element and tried, and some of it worked and some didn't. But when we look at it today, this is the recipe that you will have to use. I'll just skip this one and say, and that was also, the disparity in outcome was also the reason for having a Utstein meeting in 2015, as we heard yesterday, and as Tom just referred to. We had an Utstein meeting saying, how can we change survival rate internationally? We haven't seen much changes for the last 3 decades, and we have seen a huge disparity. For instance, Seattle being the world leader in this field, and others being in the bottom. A lot to achieve still. And so we had this meeting, what to do now? And actually what came out of it was that we agreed on the 10 steps or 10 programs to improve survival, and then we established the Global Resuscitation Alliance as a tool to help others to achieve what can be achieved. I would encourage you to go to this white paper actually with the link. It's on the Resuscitation Academy Foundation homepage. It's worthwhile looking at the cases there, but also use the recipe to improve. And part of this is also the chain of survival with a frame that includes leadership training, quality improvement, and culture of excellence, which is very important. And the aim of the Global Resuscitation Alliance is to improve survival by 50%. So in Seattle, they will have difficulties. In Copenhagen, we will have difficulties, but we will try to do it. And in other part of the countries or in other part of the world, they will also have difficulties, but have more potential to what they're actually doing. Just to mention the final slides here, the Global Resuscitation Alliance is really global. These are the organizations being part of that. It's the Asian EMS Association, it's the Council Ambulance Authorities in Australia and New Zealand, it's the Leadership Network in Europe, and it is the people from Seattle, including Resuscitation Academy Foundation, and Thor Lerdal is supporting it by the Lerdal Foundation. This is the board that is going to help others to improve. We have developed an assessment tool for EMS systems, so you can see how you can improve further. We have working on developing a dispatcher-assisted program, very much based and in collaboration with AHA. We are developing a high-performance CPR program, and it's all going to be for free for people who want to use it as part of the Resuscitation Academy. And then we are adapting the 10 steps to improve survival for developing EMS systems. And we had a meeting in Singapore two months ago, and actually what they said, the developing EMS system in where actually most of the people are living, they said, well, we can use the 10 steps, we just need to adapt it a bit. So that's short. So in summary, we triple survival in Denmark nationally and improve quality of life for survivors as well. We did that by engaging the community, which is the most important thing in my opinion, and through increase of bystander CPR. I also think that dispatcher centers and bystander interaction is the key to improve further. And of course, we all have the Global Resuscitation Alliance to help us and the tools there, including the Resuscitation Academy. So thank you very much.